This meeting is being recorded.
So if we don't know what happened, we can just go around, discuss, and everyone's going to give an opinion. So, but we don't really know if we are right or wrong. So this case is interesting because there are plenty of changes, and then also because we later on I will show you a CT, and even more we have histopathology of the case. So makes it a very nice case. The probably not so nice situation is that most of you know it, so there's not going to be a lot of, for some of you, a lot of surprise, but that doesn't matter because we still the opportunity to go more in detail through the case and probably revisit our assumptions and the way we read it first. Okay, so this is the case. Let me come back to the history. So now that displays okay. So it's a young dog. It's a 2-year-old, 2.5-year-old dog. And then the clinical signs, from what I remember, there's a lot of detail in here, but basically what I remember is that the dog always was, the main problem was coughing, and then it got into dyspnea. It was really never improving. Probably someone wants to interrupt me and give more, a better background about the case, but from what I remember, it was, that was the issue.
I saw it about 4 weeks after the initial clinical signs of coughing. It had been treated with doxycycline with no response. And then I think they'd just started a moxiclav, and it had chest x-rays at its regular vet. And then I recommended a CT at that point, but they decided not to. And then a week later, it presented really dyspneic to Helen.
Yeah, and it basically had pretty much every medication you can think of. I think it had been on antifungals and all the different antibiotics, and basically nothing was working.
Beautiful. So that's the background. It's a young dog. It's not responding to any treatment, a variety of treatments. And then we have this set of images. So let's go through the findings. Yeah, as we usually do. Again, I insist, then in this case, it's beautiful because things that we may be considering or not seeing, then are going to become more clear when we run through the CT. And then on top of that, all the considerations that we may have now, then they're going to be proven right or wrong because we kind of have the histopathology. And then that is going to allow me then to go a little bit, do a very short literature review about what we are dealing with. So I hope makes a nice case. But anyway, so take a look. You may have an opinion. Some of you, the ones that you haven't seen the case obviously don't have an opinion. So I think the discussion is going to be interesting. Obviously, in this case, probably I'm not going to ask the question if it's normal or abnormal, because the answer for that question is very obvious. But okay, so let's start with the changes.
I can't see the radiographs.
Yeah, me either. I thought it was just me.
Because I thought I was sharing the screen. So share screen. Oh, I'm sharing the wrong screen. Yes, I need to share this one. Is it better now?
Yeah.
Perfect.
Okay.
Thanks.
And you tell me if you want to, whatever, magnify, minimize, get only one image, whatever. Oh, it's not normal.
Okay, I'll start then.
Well,
There's increased opacity in the dorsal and then I'll have to get my annotate up. Increased opacity in the dorsal and caudal lung fields there. Perhaps here as well. And then your sternum, in the region of the sternal lymph node. But the cardiac border is well defined in both the lateral views. Not so much in the VD.
Okay. So if I ask you in particular about this increased opacity that you, I think correctly localized kind of dorsally, if I need to ask you where is that abnormal opacity in the other projection, where will you go?
In the VD, it's here, and it's actually the opacity, but probably not the anatomical structure, is visible, extends into the abdomen, whereas the diaphragm line is noticeably intact in both the lateral views, but also around here, and to a lesser extent further forward up here. The other side is, yeah, there's a degree of opacity there as well, but the heart border is well defined on the left side in the VD, but not so well on the right, whereas it's well defined in both the lateral views.
Beautiful. Very good. So then we have that overwhelming or very, very clear increased opacity. I'm not going any further than saying that there is an increased opacity because I want you to go further. Increased opacity, and I'm going to just leave it that based on the localization that is in the right caudodorsal aspect of the thorax.
I'm not recognizing a distinct lung pattern. I can't say it's a bronchial pattern, and it's not an alveolar pattern either. So I'm thinking it's probably, I didn't get the age of the dog, but I think it's probably more of a, yeah, I'd hardly call it a mass effect, but because yeah, it could be a neoplasm.
Okay, so it's in the thorax. No, I assume that you are now, and I'm no question, whatever. I'm no question. I'm just trying to make clear about this. So now you are, because you are talking about the lung patterns, and then you are assuming that is in the lung. Because if I'm a vet and I'm not a radiologist and I'm just listening to you and I don't have the images in front of me, then that increased opacity in the caudodorsal thorax actually can be in many anatomical places, you know, so it could be, I guess, in the wall, it could be, as you mentioned, it could be, you know, a hernia, so it could be coming from the abdomen. I suppose it could be a pocketing of fluid in the pleural space. I mean, it can be in many anatomical locations. I assume you are, because you are talking about lung patterns, are you then therefore assuming that it's in the lung? What's your, and this question is for everyone. You know, just as we started the discussion, is that increased opacity is very obvious. Then the next point that should be a natural point to go is where is it and how certain we are about the localization.
I think it's within the lung because you can see an air bronchogram going through the middle of it.
Okay, good. Can you show us that air bronchogram?
Oh God, hang on.
Just while she's doing that, Mariano, Bronwyn pointed out that we've got 2 left laterals up rather than a left and a right.
Oh, well, oh, yes. Ooh,
Sorry.
no, you're right, you're right. There we go. Beautiful. Yes, thank you, Helen. That line shows that airfield airway is the principal bronchus going to the right caudal lung lobe, I think. So it is there. So I agree with that. And I would probably use that. Yeah, so that airway is gas filled and is surrounded by soft tissue. So that's the definition of an air bronchogram. And then that is basically telling us that if not all of that, at least part of that has to be lung. Makes sense? Because if this would be outside of the lung and the lung still contains some gas, then we should be able to see some vessels in that lung. And we don't see any vessels in the lung, we just see air within that main airway. So yeah, that is telling us that at least part of what we are seeing is increased opacity within the lung. Then we have to explore that more. Okay. Any other feature about that air bronchogram? Because I think there is more to it. So I clearly see it. I think it's allowing us to assume that is in then the abnormality is most likely in the lung. Is there anything else that we want to say about that opacity?
Not about the bronchogram, but I thought the cranial aspect of the opacity looks consistent with like a lobar sign.
Very good. Very good. I think that's an extremely important point. So the border of that abnormality somehow is respecting the border. Then what we expect is the border of the lung. And it has a normal shape, almost I would say a normal position. Probably it's a bit more cranial, but if it's a minimal point. The important point here is that it's smooth and it has exactly the shape of that lobe. Yeah, excellent point. I think that's a very important point in this case. Anything else about that air, in particular about that airway, or if you want to, anything else?
It's quite narrow for the main bronchi to be so narrow. And the other thing is the heart seems to be being displaced to the left because it's quite a straight DV. And the heart seems to be being pushed over. So it's like creating like a mass effect.
I signed those 2 findings and I believe they are extremely important. So one, and there is, I will add one more. So that airway that we see is clearly narrow compared to the opposite. And it's not only that, but it's also displaced. Makes sense? So if you look at this one goes more naturally, probably is also displaced that way to the left. But this certainly is displaced also to the left. This should be more like here. So this is narrow and displaced. And then there is a mass effect or mesostanal shift to the left, away from the abnormality or the main abnormality. Okay, very good. So it's has a lobar distribution, increased opacity, lobar with a mass effect, and it's affecting the airway. Yes, anything else?
I'd also agree with Jeff that the rest of the lung doesn't look normal. On the right cranial side, it's quite sort of, I guess, interstitial, if you want to put a name to it. And the left cranial's sort of similar as well. So it doesn't seem like a wholly one area defined problem. It seems like a bit more of a global problem in the chest.
I completely agree. So this is the abnormality in the right caudal thorax is dramatic because it's soft tissue opaque. So we expect lung to be there, and now there is really the only air left in that lung that we can see is just within that main airway. The rest of that lobe is extremely abnormal in terms of all the gas is being replaced by fluid or cells or something that is soft tissue. But then if you pay attention to the rest of the lung, probably the left caudal angle is a bit more normal based on how well defined are the vessels. But if you go more cranially, in particular where we think the right middle and the right cranial are, then there's an increased opacity. If you go in the lateral projections, it's very hard to see the vessels, so there is a diffuse increase in the lung opacity. Either, I guess you can call it like a very heavy interstitial, and I think in some areas there is some alveolar pattern as well. So very abnormal lung. Yeah, seems to be worse on the right. The left is not normal, but it seems to be less affected. Anything else?
I think there's pleural effusion, although I can't be 100% sure, but I think you can see lines on the right-hand side. And I'm sorry, I missed about 2 minutes of the conversation earlier because I just didn't have any sound. So someone may have mentioned this, but if you look in the right caudal area on the VD, again, I'm going to struggle to highlight this for you, but I think you can see lines indicating that there is separation in there. And I also think that the boundary between that, the density and the edge of the ribs, you've lost any definition there at all. I guess that could be the mass, but I think there's probably fluid in there. And the only other one thing I wanted to say, I can't really explain this, is the definition of the heart. And Jeff mentioned it. It stands out, the heart, as if it's got a silhouette, not a silhouette, but a dark line around it. And I can't quite explain that. So I don't know whether that's, well, I don't think it's fluid. I don't think it's air. I guess it's just looking at the different densities of the heart and the contrast against the lungs, but I can't explain it.
Okay, good. So in terms of the pleural effusion, I think I would probably pick this line to think that there may be some pleural effusion. It's a young dog, seems to be a bit wider to the periphery. So I would probably pick that one. I would have a hard time being convinced about a line here, just because it's, even if there is pleural effusion, once the pleural effusion is against that abnormal lung, then we are gonna be unable to make a call. If you go by how, one of the features of pleural effusion is that pleural fissure lines, but then another one is separation of the lung from the wall. So we could kind of analyze, and pay attention if there is any separation, and it's questionable. I'm not 100% convinced. And then, as you mentioned, then if you want to entertain the idea of pleural effusion, then you want to see the borders of the heart being effaced, and then we see the opposite. So then it's a very questionable comment. In terms of how that dark line that you see around the heart, I have anecdotal, I remember making the same point, and I don't remember who, but someone mentioned this, and I don't know if it's real or not, and probably I don't remember coming across this reading, but there was the comment that you may be just lucky to get the radiograph during systole, and then you get that. It's almost like a motion artifact, and I'm not sure if sounds like a reasonable idea. I guess the only other consideration that I will have, just because it's so clear, the border is so clear, is an increased delineation, or then it is having gas in the pericardium, but I don't think we are dealing with that situation. So then I probably pay attention to that, think that we are lucky and we are taking that radiograph during systole or whatever, and then kind of ignore it. Anything else? I guess there is probably one more finding, and then we need to start playing around and thinking about how to explain it. And the other finding that I would probably mention is that the trachea seems to be displaced. We always we spend like a couple of cases or whatever rounds discussing about the trachea, and we pay a lot of attention, and Remember, depending on how the bifurcation, the most covered part of the trachea and the main bronchi move, then we have a lot of considerations. We go left atrium, lymph nodes, heart-based mass. Do you remember we went through all of those cases, and then we also went through the vascular ring anomaly. So knowing about the trachea, knowing about the main bronchi is a very important tool. And here we already decided that this is displaced. And I think the trachea is ventrally displaced. So I remember seeing that, and then I can give you what I thought at the time was the explanation, but I think it's worth mentioning that. And the other thing that is worth mentioning is how flat is the diaphragm. The diaphragm seems to be, usually is more kind of rounded or convex towards the thorax and looks very flat. That is a feature, is a non-specific thing that happens whenever we increase the volume in the thorax. So then the diaphragm goes cold and gets flat. So then that goes with having a very large abnormal something in that lung. The thorax seems to be getting enlarged and then the diaphragm being displaced currently. Okay. Okay, now let's start hypothesizing. You know, how can, so summary. So summary will be, there seems to be severe lung disease. I think we all agree with that. And there are kind of two different morphology, if you want. One is a lobar disease that is not only lobar, but there is within that lobar abnormality, there is mass effect. So the lobe is enlarged, and also the structures within the lobe, like the airway, is being displaced. So that's the way that we have to define that abnormality in the right caudal thorax. And then there is a severe diffuse increase in the lung opacity, and then we can go based on patterns. But it's bilateral worse on the right. Yeah, and then displacement of the trachea. I suppose we are there, and probably a minimal amount of pleural effusion. So how are we going to put all of this together in a 2-year-old dog that is not responding to treatment? What are the hypotheses? You know, what could be going on wrong?
It could be.
If it-
Sorry.
You go.
It's a bit hard because I know the answer, but pretending that I don't. Like, even though it's a young dog, you'd maybe say it could be neoplasia because with a secondary pneumonia causing the changes in the other lobes, or a consolidated lung lobe secondary to a severe pneumonia.
So keep the others. Let's explore the area of neoplasia. So how can we put together, so the classic, if I mention lung mass, the classic lung mass is going to be like a tennis ball, you know, so it's a mass. You see borders, you see a soft tissue thing that is usually rounded, usually well-defined. And then that's the textbook, you know, whatever comes to mind immediately if you say lung mass. This looks different from that textbook. So, and I'm not saying that you are not right. I'm saying, how can you explain what is happening in this particular case where the neoplasia is looking so differently? How can you reconcile neoplasia with that lobar disease?
If it was like an infiltrative type of neoplasm, like as in something that caused a mass.
Cool. So that will be one answer. So then I guess two types of neoplasia I would want to mention there is the histiocytic sarcoma and maybe lymphoma. So that's different from a pulmonary carcinoma. So your carcinoma usually is like the classic tennis ball, whatever, well-defined. Now there are other disease processes that can go more kind of a diffuse infiltrate. And then for that, the idea of histiocytic sarcoma is a very good one. So you can go with a combination of nodules, diffuse increase in lung opacity, and alveolar pattern. So if we want to make this right caudal lung lobe like a severe alveolar pattern, which I think we have the right to make. then histiocytic sarcoma kind of goes. What the other point of histiocytic sarcoma is that the lymph nodes are usually enlarged, and in this case, the trachea is displayed. So then you know that fits as well. So I think that's a good idea. And lymphoma plays a similar role. So lymphoma can go with nodules, diffuse infiltration, and then lymph nodes as well. So those two, I believe, are the two neoplastic processes that we should consider if we want to play with that idea. So continue. Any other differentials?
I think given the age as well, and the fact that we're getting a mass effect, I'd be thinking something like a granuloma as well. So like an infectious cause, like a chronic fungal infection, those kind of things, or potentially a chronic foreign body. It doesn't quite fit the subtlety of the history. I think if it was something like a foreign body, it'd be much more. Or I mean, it was just a subtle, wasn't it? That's how it presented. I think, but yeah. So I'd be thinking something like a granuloma, or it doesn't really look like it, but maybe like a torsion.
Okay, so before going away from granuloma, and I suppose next to granuloma, you're going to put, if you're thinking about an airway, foreign body within the airway, then you have the idea of a granuloma together with the idea of an abscess. There are the differences. One is more fluid filled, the other one is more solid and probably more chronic. So again, I ask the same question. How do you reconcile that idea with our inability to see something like a mass?
Yeah, no, I see.
Again, if you mention like abscess, my brain goes, well, mass, or even granuloma, and I'm not seeing any of that. So how can you reconcile? I'm not saying that it's wrong. I'm trying to
maybe if there's
visible our thinking about it.
Yeah, could there be, so if there was a granuloma, you might have, or like playing with the idea of an abscess as well, that you get this lobar pattern because you've got an element of pneumonia as like with that granuloma, or so maybe there's fluid surrounding it, feeling kind of creating that lobar pattern.
Okay, so the way that that would work, and I think there will probably go more with the idea of an abscess rather than with granuloma, is an abscess can break into the airway. And that goes again also with a hematoma or something like this. So then you can have a disease that in nature is rounded and it should produce some relatively well-defined borders against a more aerated lung. But then if that disease that contains some degree of fluid opens into the airway, then you have like an alveolar pattern created by that fluid that goes around the mass. So then you don't see it. Make sense? So the mass results in a lobar pattern. It erases all the borders just because of the abnormal lungs surrounding that mass. So I like the idea, and actually, I personally entertain that idea a lot. Young dog. So if you think about it, young dog, it could have a foreign body. The foreign body, probably more than one, or the foreign body was going around there, resulting in pneumonia, and that there we can explain the changes in the lung, and more probably why they are more unilateral, even though the left is affected. And then one piece of the foreign body went into that right caudal lung lobe, creating an abscess, and that abscess is let's say oozing or is communicating with the airway, and then that is resulting in a lobar pattern. And if you go along those lines, then you can explain why there is mass effect in that airway, because there could be an abscess pushing that airway. And then also why the overall volume of that lobe is increased, because now you have that fluid and that inflammation in that lobe. So I kind of like that idea. It's a young dog, and so I don't think in this case we have a clear-cut answer to everything, but I think it's an idea that we can entertain. And then what else would we consider, or we should consider?
I think Josh already mentioned it, but lung lobe torsion, except for it's not the classic lung lobe to be torsed. But I mean, I guess it's possible, or isn't it possible to have a right caudal lung lobe torsion?
Yes.
Well,
So there is a but here, and then I'll try to bring another like a one torsion. One feature that is almost always there, and I want to I say almost, and I would probably remove the word almost, and I would say always. I need to double check in the paper, but I'm thinking it's always there. Is a generous amount of pleural effusion, and then there is always the idea about, is effusion the cause of the torsion or is the consequence of the torsion? I think it could be both, but once you have a torsion, then there's going to be production of fluid, and then usually when you see, then there is a lot of effusion. In this case, we have a question mark about effusion, and if it's there, is mild. Then the things that fit is the mass effect in torsions can go towards the affected side or away from the affected side, and that depends in where in that process you take the radiograph. So initially, I think the lung gets larger and then gets smaller than the torus lung, and there's a combination of obstruction of the airway and arterial supply going abnormal venous return or block venous return, resulting in edema, and then a characteristic vesicular pattern. That pattern is kind of missing, but I guess it's not present in every case. So that's a good idea. What we are missing, what wouldn't fit in this case with the torsion is the absence of pleural effusion and the abnormal, the severe abnormality of the rest of the lung lobes. So again, I'm just thinking aloud, and this is the exercise that we play when we do hypothesis testing. So again, I'm not saying, completely no, it's a good idea, but we always really want to test the ideas and see, how many of the findings can we explain with that hypothesis and how many we are leaving out. Okay, anything else?
can I ask the crew, I've not knowingly, anyway, unless I missed the diagnosis, of ever had a lung torsion. Would the history be more acute in this animal? If we go back to our patient and go, does it fit the patient, or can you get chronic effects?
I'm not sure I know the answer to that question. What is coming to mind, and please, anyone else, I mean, I just want to say one thing, and is, I guess the way that I see progressing if you don't treat is that there's going to be more and more and more pleural effusion. So that's the way that I think would unfold. Makes sense? So
That's
early on, yeah.
I was going to say that's been my experience. I've only ever seen it in pugs, but they present with a soft cough, which is not very acute, and usually present with pleural effusion rather than the actual lung lobe torsion.
Interesting, really interesting.
So in my mind, I always remember the characteristic things of the torsion, and probably another thing, but it's hard to decide in this case. So is the trachea is almost always abnormal. There's always some degree of rotation of the trachea because again, there's kind of pulling of that airway and reaccommodating in that space of the abnormal lung lobe. In this case, the trachea never really looks normal, so that is there. Then the other feature is going to be this vesicular pattern in the lung, but it's not a condition. It's not always there. The other one is going to be, again, mass effect towards or away, depending on where you are in that process. And then the other one that, in my eyes, is always there, as in almost in every torsion, because of the abnormal blood flow, is the effusion. And in this case, being so chronic, not having effusion, I think, and not having had a history of effusion, in my mind, that almost rules out like a torsion. But in this part of the workup of a case or discussing about a case, being creative pays a lot. So everything that I'm saying and justifying why it fits or doesn't fit, it should not make us shy. Makes sense? So when we are doing this hypothesis testing, I love the wild ideas because it's very, if they don't fit, it's very easy to say, no, it doesn't fit, let's don't play. So you're gonna pay a high price if you're not creative. Makes sense? This is the part to be creative. This is the part to say, just bring everything that you think about And then sometimes just by considering it, you say, oh, no, I haven't thought about that. Now everything fits well. So this is the part to be really creative. And honestly, the idea is that there is no really wrong answers, because we are playing a game and we are seeing, what fits best. Okay, any other idea?
Mariano, can I ask about what we term hepatinization of the lung lobe? Is that just more a gross or histopathological diagnosis and it's secondary to chronic pathology like pneumonia? Or can you, because when I saw the BD or the DV, it looked like a diaphragmatic hernia. It looked like part of the spleen or the liver there. So can you use that term radiologically, or is it more a pathological sort of gross change?
I don't know, and I don't feel that I'm any authority to allow you or not allow you to use that. I think it's good to go to the meaning of what are you trying to say. What you're saying is that now, like a normal gas-filled lung, it turned into a fluid-filled lung or soft tissue opaque lung. So and there you can make it easy and say it's fluid or cells. And probably one more condition is that it's not like a mass, because a mass will look like a mass. It will be like with rounded contours and well-defined contours. So there could be a mass inside, but basically is retaining the shape, but now the gas is replaced by soft tissue being fluid or cells. So it's kind of a very severe alveolar pattern or a lobar pattern. So based on this is a beautiful example to think like that. Now let's think for a minute. Do you want to think about, can we think about this being a hernia? And again, we just play the game. What are the things in favor? What are the things against? So
well, in favor, I guess on the VD, we can't see the diaphragm on that right-hand side, and it looks like a continuation, and it looks like that, abdominal organ up there in the chest. Particularly because rostrally, that, as we already said, that lobar pattern, it's so well defined. It just looks like a bit of liver or spleen. But then on the laterals, it doesn't.
Well, I give you one more in favor. So this hypothesis testing is beautiful because in order to do it right, you need to first be able to identify what is going on, and then to be able to contrast that against like a mental scheme of what a disease, how a disease looks like, or what are the different features of a disease. So we've done that with the torsion. Makes sense? So we say, well, now we identify we can characterize the abnormalities, and now we are going to put that against our mental representation of a torsion. And then I said, in the mental representation of a torsion, these are the features. So that's the knowledge that you need to have. You need to say, well, in a torsion, usually it's this lobe, usually the lobe can be enlarged or small, usually the trachea looks rotated, usually there is effusion. So we contrapose, we put that against what we see. So you need that knowledge. Now, in terms of hernias, what we need to know is that there are direct and indirect signs of hernia. So the direct is you being able to see an abdominal structure in the thorax. Makes sense? So that's easy. And usually I would suggest we leave that for gas-filled structures. Makes sense? Because otherwise it's very hard to decide, is that lung or is that liver? But if you see something looking like the stomach, or if you see something looking like the small bowel, then there is nothing looking like the small bowel in the thorax normally. So then you just go with the first way to characterize a hernia, which is identifying abdominal structures in the thorax. Usually that's not the case, usually they don't present like this. If you're lucky, you see it, and many cases are like that, but many cases are not like that. So when you're not dealing with that, so we go with what we call indirect, and the indirect is silhouetting of the diaphragm. And in this case, we have this problem that we have the silhouetting of the diaphragm in one projection, but not in the other projection. The diaphragm is a complex structure. So could it be a rent? Could it be something small? And I guess we could entertain that idea. And then there are two more features. One more feature is the mass effect of cranial displacement of thoracic structures. And that should make sense. So if you are moving something from the abdomen into the thorax, then you have a mass effect, usually going cranially, also dorsally probably, in the thorax. And then the other one is you have a similar mass effect in the abdomen. So that's why I minimize the images, because when you entertain the idea of a hernia and I don't see gas-filled structures, then my immediate reaction is, do I see mass effect? And I see mass effect in the thorax, and it's going cranially, and it's coming from that abnormal. So that ticks one of the features. And then I need to go into the abdomen and see, do you see any mass effect, any displacement, any cranial displacement? Is the stomach too close to the diaphragm? Can I see the liver, or is the liver gone? Can I see the spleen, or is the spleen gone? And everything that I see in that cranial abdomen looks normal. And that is telling me that is very unlikely to be, but that's kind of the thinking process. And then one more feature, and this comes close to the torsion. Usually the cases where we diagnose complicated hernias are cases where, first, we don't see gas-filled structures in the abdomen, just because the liver decided to go and not the stomach or the small bowel. But then, in addition to that, one other complicated factor is that it's almost always there is pleural effusion. And again, for the same reason, there is a liver lobe that goes through, arterial blood supply keeps going, venous return is compromised, and then there is production of fluid. And then that's the way that they show up usually. Make sense? So, but again, I'm somehow celebrating your idea, but taking all this time to think around. Usually we don't just say no without going through the whole process, but because going through the whole process is a good exercise, and we may find that we are not thinking right. Makes sense? So all ideas are welcome, and then we need to really, the exercise is seeing, identifying what we see, trying to characterize, and then that requires the knowledge. So when you are reading the book, the idea of reading the book is that now you have available that information to put it against what you are seeing and see if it fits or it doesn't fit. Okay, any other consideration?
I guess not in Australia, but we have to, well, rarely in Australia, we have to put chronic sort of viral distemper, for instance, and viral bronchopneumonia, and then maybe then getting your secondary granuloma or chronic pneumonia.
So good consideration. That can explain some of the findings, and probably the findings in the lung. Again, we go with what fits or what will not fit. What will not fit in this case is the distribution of the changes. So remember that we want pneumonia to be primarily ventrally distributed, and even in distemper. So the distemper can produce a diffuse interstitial pattern. And if you have a complication, like a bacterial complication, then that usually always ends up in the ventral, because all the clearing mechanisms are compromised. And then, so in our mind, we want to make pneumonia, either aspiration or bronchopneumonia. Probably the pure bacterial pneumonia, which is hematogenous, can be more diffuse, but it will very rarely be primarily dorsocaudal. That the pneumonias don't like going like that. And then we have the most important finding going dorsocaudally. So that, again, good idea. You explain some of the findings. There's a big, is it trying to fit like a triangle into a square? There's a point where it doesn't really fit. Anything else?
Can I just ask, I think on the VD, like it makes it look like it's really homogeneous across the lung, but on the laterals, it looks like it doesn't affect all the lung lobes so much. There seems to be the kind of white, like extra increased opacity through the middle, and then it's kind of darker at the outside. I'm just wondering whether it's not as like diffuse, not, well, it's diffuse, but like not as consistent throughout the whole lung lobe as maybe the VD makes it look.
Like in this, you're talking about the right cowl lung lobe.
Yeah, so like on that view, the VD, it looks really homogeneous, like it's all the same whiteness, but on the laterals, you've got, it doesn't look so lobar effectively.
Yeah,
I don't know
good.
what I'm trying to say. I'm just wondering whether it's like not the whole, like there's actually is an area of it being worse through the lung, but maybe it's like on a horizontal
I think
type thing.
it's a good idea. It's a good idea. I just want to mention one thing, and is that be aware that even if it's all affected similarly, you in the lateral projection, in particular in the right lateral projection, you will still see these vessels because these vessels belong to the left.
Yeah, okay.
Okay, and you have them superimposed.
So they're highlighted, yeah.
Okay, so not so much if you have a left lateral projection, because now this is atelectatic, so that's the reason why you don't see this very well. And then these ones are not gonna get, the disease is not gonna change the appearance. So then, and it fits. So in the right lateral projection, we see the vessels in the left lung a lot more clear. Here we almost don't see any vessels. So that works okay with our expectation. But if you want to be very thin in this, and I think you're right, like if you go up here, so that is looking at both lobes, the right and the left, the opacity seems not to be that bad. So it probably somewhere here, this lung is not as affected as this lung, let's say. I agree, but I'm not sure that changes a lot the way we are thinking.
Yeah.
So let me, because we are running out of time, and then let me show you the CT. Okay, so. Oh, so let me open two. So I'm gonna open the lung. Okay. So with this one, it's a soft tissue reconstruction with a soft tissue window and post contrast. So basically, this is good to look at tracheobronchial lymph nodes, vessels in the lung, mediastinum, things like this. This is probably better to see changes in the lung. Okay. This is also good to see the inside of the lung. Makes sense. So how are the vessels looking like? Are they displaced or not? Do we see a cavitary mass? Do we see something enhancing in that lobe? Okay, so we go through. So first, the right cranial lung lobe is severely affected, probably more than we thought in the radiograph. They are kind of air bronchograms. So we see that airways, gas-filled airways, probably that one is a nice one, okay? Now we are seeing a lot more. This is a kind of a widening of the mediastinum, and that airway is going through something abnormal. So if you go back to a normal case, then this, I think, belongs now to the mediastinum, and it's very abnormal. So there was something there that was hard to see in the radiograph, but it's very clear now. So we follow the airway, this abnormal lung. Now we are going also, all of this is abnormal mediastinum, somewhere around the tracheal bifurcation. So based on localization and based on that well-defined border compared to the lung, I want to put it in the mediastinum. I think it's going to be very hard to be certain that it's not in the lung that is going and extending around the airways. There shouldn't be a lung around the tracheal bifurcation. The lung should start more laterally. So the fact that that soft tissue opacity is going around the tracheal bifurcation, yeah, I think I need to put that in the mediastinum. So that is kind of a new thing that it wasn't that clear in the radiographs. We described the displacement of the trachea, but it wasn't that clear. Now, this is not mild, this is dramatic. So all of this is abnormal mediastinum, abnormal lymph nodes. And then we go into the abnormal lobe. Okay. This is what we call the lobar. And then, so now there is a mixture of mediastinal disease and lung disease. And this is the reason why we couldn't decide that so nicely in the radiograph, because it's soft tissue against soft tissue and they are silhouetting. We see the narrowing of the airway, and that lung is almost all abnormal. Lucy, you were right, some of that lung dorsally is not that affected, but most of the lung is affected. And we don't even see airways or we see vessels extending, and some areas they kind of resemble airways, but the architecture of that lung is completely abnormal. And this kind of a rounded thing. So I think there is, again, the architecture is so abnormal, it's very hard to delineate. This is a mass surrounded by abnormal fluid-filled lung. Probably you could make that call and say, this looks like a mass, and then this is probably looking up slightly more normal, not in terms of the opacity, but in terms of the architecture. And that can be fluid extending into the surrounding lung, and that's a mass. There is a place here where even the vessels are kind of embolization or invasion of the vessels. Okay, so a nicer image of what we already saw in the radiograph, plus the certainty that now we are dealing with something also abnormal, a very abnormal tracheobronchial lymph nodes. Okay, so I just wanted to show you that. And then probably because we are running out of time today, we've taken samples. We still were uncertain. Probably the minute that we saw those lymph nodes being so abnormal, I think the idea of the abscess, I think, went down in the list, and the idea of neoplasia went up in the list. And I regret to say that we were not thinking about what it actually was. Which,
thymoma has that appearance, I would have thought.
But no, the thymoma should have a mass in the mediastinum, but in the cranioventral mediastinum. This is really tracheobronchial lymph nodes. So I think there is this differential. So it came back as an eosinophilic pneumopathy, extremely severe. And so now this is just 2 minutes of a literature review. So there are two very interesting papers. I recommend reading them. They are just lovely papers. Probably this one in particular, if you want to read like a very nicely written paper, it's a pleasure to read it. All the organization, their hypotheses, their material, the way that they present the paper is just, it makes you happy. And this one is also very good. And then there are kind of two diseases. They are uncertain if they are dealing with the same disease. This is what they call eosinophilic pulmonary granulomatosis. In this case, their cases were mostly characterized by masses. So pulmonary masses or nodules. And then they describe this honeycomb-like enhancement pattern. And I think, looking at the images, they think that is abnormal distended airways, bronchi, that they are enhancing, filled with hypoattenuating areas of necrosis or fluid-filled airways. Going to our case, I think we may see something like this. I think probably we are dealing with something like this. I would probably say, ooh, I went too far. Okay, let me grab this. So we are coming here. It's not with the airway, but I wonder if this is a kind of a radiolucent or a radio opaque halo around those vessels that kind of resembles that honeycomb appearance that they are describing. But again, this paper is basically describing nodular or masses and this enhancement within the mass. And interestingly, only one dog had tracheobronchial lymphadenopathy, but it had. So this kind of fits. And then the other disease where they are uncertain if it's the same is eosinophilic bronchopneumopathy. And in that case, even though some of the cases were they had nodules, the airways were clearly and severely abnormal with many abnormalities: bronchiectasis, thickening of the wall, plugging of the lumen of the airway. So I think our case looks more like this one, like the eosinophilic granulomatosis, rather than the eosinophilic bronchopneumopathy. Interestingly, in this one, they describe one case with a lower distribution. So, you know, there we are in between. And then also describe lymphadenopathy in more cases. So maybe we're dealing with the same disease. In some dogs presents more like an airway oriented, some dogs more like a mass oriented. Interesting pictures. The airway oriented abnormality is severe. I don't think we had that clear airway oriented. It was more, my eyes more interstitial and mass. But they also describe a case where it looking like a mass, very similar to our case. So they just decide, or they mention that they are unclear if this is the same disease that is progressing from one form to the other, or we are dealing with the two diseases. I also thought about sharing with you differentials to consider in cases like this constellation, this grouping of findings, and they consider lung neoplasia, as we consider pulmonary lymphoma, histiocytic sarcoma, lymphoid granulomatosis. I'll try to find a case of this sometime in the future. Abscesses or granulomas. So, you know, we were in the area. Sadly, we haven't considered this. I think the lobar thing pushed me away from thinking about this disease. And then I thought about sharing with you how to think about lobar, because, and I was trying to include that as we were discussing, you know, so what are the disease mechanisms with which we can end up with a lobar? And something we haven't considered, because it's very obvious not the case in this case, is atelectasis. But, you know, atelectasis, either because you compress the airway or, yeah, then it can result in a lobar. But in that case, it will be reduction in the size. In this case, we had increase or enlargement of that lobe. So then, even though, but that's something that we should consider when we are thinking about lobar. Obviously, not in this case. Then the other differential is neoplasia. And again, here is saying something, okay, most of the neoplasias that they are listing here are associated with the airway. And that makes a lot of sense. And it's very common in cases of bronchogenic carcinomas in cats. You don't see the mass, you see almost like a lobar or a very severe abnormality with ill-defined contours. And it's the mass either growing through the airway or leaking into the airway, and then that obliterates all the borders of the mass. So that's another mechanism that we talked about that today. Lung lobe torsion certainly is another one. There are many more findings in lung lobe torsion that I think you can. When you see the lower, it's perfectly fine to think about lung lobe torsion, but then there are many other findings that it's good to wait before going. And then the other one is the occlusion of the bronchus. And there you can think either about a neoplasia occluding the airway, but you can also think about aspirated foreign bodies or something from the outside compressing the airway. So it's a very big way of thinking about it. Compression of the airway, pulmonary thromboembolism or fat embolization secondary to fractures. I think that's more common in human medicine. But I thought about refreshing. For me, reading or knowing is being able to bring a lot of differential diagnoses, a lot of options for each feature that I find. I feel happy when I can recall that, even if I then trash them. It's a good idea and it's lovely to be able to see, well, I have that feature, and then these are all the options that I should consider for this feature and this feature, and then putting them together and then going with a reasonable list of differentials. And this for me was a teaching case. I was too attracted by the lobar. I am happy that I never really strongly considered the lymph nodes. I thought it was the lung that was so abnormal displacing the trachea, and therefore I never entertained this differential that much. I think the case worked up very nicely anyway, because we did imaging to further characterize the changes and then obtain samples, and then at the end of the day we were right. But it was a little bit of a teaching case for me, or a learning situation.
And just
Okay.
as a side thing, just on that lobar side, it said your DV or your VD is your best way of seeing it. It's interesting because when I saw the dog the week before, the ref vet had done only laterals, hadn't done a DV or a VD, and like it wasn't as bad as the ones that Helen took, but there was like this white area dorsocaudally, but you didn't really know the significance of it because you didn't have the other view. So it's interesting, like maybe if there had been a VD or a DV, we would have like got more of an answer earlier potentially.
There I was thinking, this is on a side. I completely agree with you, and I will make a comment about if you don't have two orthogonal projections, just go and take it and then come and talk to me. It's completely unacceptable. So, and it's just
interesting. I think they'd done sort of conscious ones and they'd kind of got what they could, which was like, you know, it happens, that's fine. But it's just interesting that it says like the DV or the VD is the best view, and that's the only one we didn't have. So it's kind of a lesson learned, really.
And then the other day I was thinking about, so this, and I take it for me, and I'm not saying I'm good, I probably struggle with this, and that's why I like it. This idea of the different views. So when you are too hard on one view, then you don't want to consider the other view. And the other day I thought about this as a very nice image. Like I know so clearly how in imaging, in particular in radiographs, you need the two views. Makes sense? And in that case, we use the view for projection. But I thought it was a nice image to think about life and say you need the two views. And they are orthogonal. They are not a little bit away. They are orthogonal. And you need both. And I thought it was this fantastic like analogy to be open-minded. Makes sense? In order to understand something, you need your view and you need your orthogonal, not one that is a little bit disagreeing with you, one that is clearly disagreeing with you. That's the best. And if you get that, then you get to understand more the process. So nothing. It was just that it came to me like as the concept is so familiar, but it became even more familiar with the idea of the views in radiographs and being orthogonal. That I just love that. Okay. We went really over today. It was a very these cases are the lovely cases because we have a lot of material to discuss. A lot, like in terms of different modalities, but also we know where it was, and then we can go through literature. So it's
just very quickly, this dog was post-mortem, was it? You said something about histopathology, or did you get a biopsy of it?
Oh, so then someone probably can talk a bit more about what happened.
We did FNAs, which came back as just like chronic inflammation, and then it went to surgery and it was euthanized on the table, and they got histo from the
when we got in there was almost no normal lung at all. You couldn't even see or directly touch the heart because all of the mass stuff was adherent to the pericardium, and there was like trying to resect, like even kind of debulking the lesion and taking out one lung lobe. It would have killed the dog just trying to get anything out. So we aborted mission.
Oh, right. Okay. Yeah.
And then that's another thing that I forgot to mention in both papers. They are young dogs, so around like young adults, or around 2 years old. We haven't included that in here, but yes, in both. So actually, that should have made this differential. Like, yeah.
I had one recently from Wangaratta, young dog as well, but more like the second one, Mariano. It was very nodular and got the diagnosis through a BAL, and thankfully doing very well on pred. So I'll send the images to you. It's interesting, but nothing like this looking.
No, so if you have those images, send them so then we can.
I've got radiographs and CT.
Oh, cool.
Is that the one with Weimaraners more prone to it, the nodular one? Or am I
Huskies,
imagining that? What's the one with Weimaraners that
I
maybe
think
I'm
Huskies.
pardon?
Huskies.
Huskies.
I think so.
I think this was well, I actually can't remember. I think it was a shepherd or a crossbreed. Anyway, I'll send them. It's good.
Beautiful. Okay. See you in 2 weeks.
Thanks, Mariano. Thanks, everyone. That
Okay.
was
Thanks,
very good.
Mariana.
Yeah.
Great case. Thank you.